good. Can you lead us off in a prayer tonight, please?
Okay, let us pray. Gracious Lord and our Heavenly Father, I give you thanks for this day, and I give you thanks for bringing us to this hour of the day. Father God, as we go into this meeting this evening, I ask that you be with us all, that you be with the speaker. I just ask, oh God, that you give him clarity of thought, and that we, the hearers, will understand, and we will be able to do according to what he is saying to us, and also to be able to guide those persons who come under the Cancer Society, who always come for advice and guidance. So right now, Father, I ask that you continue to be with us in this meeting, and everything that is said and done will be done to the honor and glory of your name. In these things I ask,
Amen.
in Jesus' precious name. Amen.
Amen. Thank you.
Thanks.
I don't have many announcements, just to say that we're still in this COVID pandemic, and we're still struggling to do stuff on the usual terms, but we have to persist and carry on. We still have our special guest in the Cancer Caring Center. So we continue to help those ones in need, especially the ones from the Family Islands, come to Nassau and give them room to stay and take them to their various appointments and treatments. Aaron, do you have any other announcements to make?
No, there's no other further announcements.
Okay. Well, we just go right into the heart of the meeting. Tonight we have with us Dr. Darren Halliday. He is a consultant gynecological oncologist at the Princess Margaret Hospital and at Doctors Hospital. He completed his medical training at UWI in the year 2000, went on and did a Doctor of Medicine degree in obstetric and gynecology and completed in 2008. He then went on and did a 2-year fellowship in Calgary, specializing in gynecologic oncology. He presently serves as a consultant at Princess Margaret and is an associate lecturer also at the University of the West Indies. He's very instrumental in dealing with the virtual learning platforms in medical education, and he assists us a lot in our communications, also at the Cancer Society. He has a special interest in, as you may see, gynecological cancers, particularly in cervical cancer. And tonight, he's going to speak on cervical cancer. So, Dr. Halliday, go right ahead. Thank you for accepting to give this talk for us.
Okay. Good night, everyone. I certainly want to thank the organizing committee for inviting me to participate in this esteemed lecture. So this evening, we hope to discuss briefly what is a growing global pandemic, one of cervical cancer. And even though we're living in an era of COVID, the deaths from cancer are still quite alarming when we consider all the global trends. We're going to look at some of the statistics. We're going to review how cervical cancer develops, some of the screening protocols and algorithms, and how we diagnose and go about treating this disease. So cervical cancer is a malignant tumor derived from the cells of the cervix uteri, which is the lower part or the neck of the womb. And that's part of the female reproductive system. Is for the layperson is essentially located at the top of the vagina, and it's dilated during labor. So that's where babies come from, as I would tell my children. The baby is held in the womb, and the cervix keeps the pregnancy and it's dilated during labor. So it has a significant function in women's reproductive health. However, because of its very makeup, it's susceptible to trauma because it has various cell types, and is susceptible to malignancy, as we would discuss. Now, cervical cancer is a common problem, and currently it is the number 3 global cancer behind breast and prostate cancer. The current estimates suggest that cervical cancer is likely to increase every year. And this data is from a few years ago. And right now, the data suggests that there are over 500,000 cases of cervical cancer annually. And many of these women die within the first year, and the majority in the developed world. It seems to be a disease of we say poor demographics, because those nations in the world where there is economic hardship seem to not deal well with this disease. And this is because the infrastructure for screening is quite sophisticated, and as a result, it could only be afforded by nations which have a lot of disposable income, and it requires a great deal of organization, and many of the developing world is not able to do this. So we see rates as low as 7 per 100,000 in places like North America and Australia. And when we get these very low rates, certainly below this level, they consider that cervical cancer is cured in your country, especially in Australia, where they have an excellent vaccination program. And the cases that develop in these regions are largely due to the migrant population, women who have been underscreened. So in the Canada and much of the world, the implementation of good screening programs is the single most important factor that has decreased the rate of cervical cancer, as this chart illustrates. Now, cervical cancer is a disease of mid-aged women typically, and that's because even though there are many risk factors such as multiple sexual partners and STDs, sexually transmitted diseases, smoking, and so forth, what has been found in the literature that the presence of HPV infection is the single most likely factor to contribute to the development of cervical cancer. And in terms of the natural history of cervical cancer, at the onset at Koitaki, approximately at the age of in the adolescent years, the persistence and the prevalence of the HPV infection is high. And the data shows that 80% of the population would acquire HPV in their lifetime. But HPV infection takes a long time to go from cancer or from HPV infection to pre-cancer to cervical cancer. So it has a long, what we call preclinical course, which makes it amenable to testing. And what we find is that in 80% of the population require HPV during their lifetime, it would persist in only 10%. And those people who have persistent disease would go on to develop pre-cancer, and later on in life, they'll develop cervical cancer. So it is amenable to screening, as we will discuss. And this chart also shows that the incidence of cancer increases with age. So at the young age, you have HPV infection. In the 20s and 30s, you have an increase in the incidence of pre-cancer, so cervical dysplasias. And as you get older, the incidence of cervical cancer increases. So if we were to ask the question, the factors associated with increase of cervical cancer, we have first coitus, that's multiple sexual partners, smoking, or what we call a high-risk consort, or whether alcohol or drugs abuse. So all of the following, which one of these do not contribute to cervical cancer? And the answer is, of course, alcohol and drugs abuse. So while alcohol and drugs may cause you to lose your ability to control yourself, they in and of themselves do not contribute to the development of cervical cancer. But things such as smoking would cause local immune modulation and immunosuppression. It's also a carcinogen. And the other factors, such as early age of sexual intercourse and multiple partners, or high risk consort, would facilitate the transmission of HPV. So, sexual transmitted diseases, especially ulcerative sexually transmitted disease, also increase the risk of HPV infection. So this is another factor that would contribute to development of cervical cancer. And HIV, which hinders, or any condition which results in immune suppression. So there's patients with SLE on immunosuppressive therapy, or renal transplant patients, anybody with on immunosuppressive therapy, they would also be at risk for developing cervical cancer because the body is not able to clear HPV. And socioeconomic status, we think, is more than their ability to not get the proper screening or have access to good screening programs. But Professor Horace Fletcher in Jamaica and others have shown that if the body is undernourished, it is in a relative state of inability to control the immune response. So malnutrition, in a sense, predisposes to the development of cervical cancer. And in terms of other factors, the oral contraception pill, it makes the cervix more susceptible to trauma, in that the columnar epithelium would come down into the cervical canal and be more susceptible to trauma. So, and that would permit the development of cervical cancer, because the virus can enter through microabrasions and infect the cells and cause the development of cervical cancer. But human papilloma virus by far is the most important risk factor. And the DES, or diacylstilbestrol, it was a hormone they used for morning sickness and has been found to associated with high-risk cancers in the female genital tract of the offspring. And this drug is hardly used nowadays. So I've certainly never seen a case in my lifetime. So question is, mature HPV particles are found in the superficial layer of the cells and the epithelium in the cervix, and the most common types, 16 and 18. And this one is the portion of the virus that is supported, what we call, that cause the cell not to die, is the E6 and E7 portion of the capsule. And there's a Harald Zur Hassan. He eventually won the Nobel Prize because of his work with respect to the isolation and showing that HPV is associated with cervical cancer. And as we discussed, the majority of the cases are associated with cervical cancer associated with the human papilloma virus. is also responsible for other female genital tract cancers. So cancers of the vulva and the vagina will be associated with HPV infection. We can certainly use our imagination to realize that based on people's sexual practices, we find a high deal of head and neck cancers and oropharyngeal cancers that may be associated with HPV as well. And it is known that for people who are involved in receptive anal intercourse, the rates of anal cancer approaches that of the unscreened population of women with cervical cancer. So the incidence could be pretty high. So nowadays, for persons who are involved with receptive anal intercourse, they recommend getting proctoscopies to look at the mucosa and screening that individual as well. Okay, so the HPV virus is quite complex. It's a small molecule, and the vaccine is developed against the L1 portion of the L1 protein in the capsule, and the other proteins, as we discussed, are responsible for various functions of the virus, including causing uncontrolled cell proliferations. That's the E6 and E7 portion, and the E4 and E2 portion is responsible for viral replication. So this brings us to prevention. So when we are looking at cervical cancer prevention, we look at it in terms of primary prevention, secondary prevention. So primary prevention is to prevent HPV infection in the first place. So this is what we do. We do vaccination. Secondary prevention is to detect the disease early. So that's cervical cancer screening, whether it be through pap smears or various other methods which we'll discuss. And tertiary prevention, which would be to actually treat the disease with the aim of eradicating it. So in terms of prevention, we're going to talk about vaccination. So there are 3 vaccines on the market, and Cervarix, which only protects against the high-risk HPV, the Gardasil, that's a quadrivalent vaccine. The original Gardasil, which protect against genital warts as well as cervical dysplasias, and the Gardasil 9, which is the new vaccine. They have additional subtypes of the human papilloma virus in the vaccine, so that there could be improved protection, because the vaccine 16 and 18, the strain 16 and 18s are found in roughly 70%. So they added the extra subtypes to allow for the other strains of HPV to be covered. Now, the quadrivalent vaccine is administered in 3 separate injections at 0 months, 2 months, and 6 months. So 3 injections are required, and this is to enable the body to have memory cells form, induce blocking antibodies, which exude through the secretions of the vagina and all mucosal surfaces, the rectum, as well as the oral cavity, and prevent HPV infection in the first place. And as we said, the Gardasil 9 has extended protection against other high-risk HPV types. So in terms of pap smears, so pap smears reduce the risk of women dying from cervical cancer by 90%. And Papillonico and Trout, during their lifetime, the rate of cervical cancer from his discovery of the pap smear, he was able to reduce, just in his lifetime, the rates of cervical cancer death by 50%. But we find that in all parts of the world, it's in the Caribbean and in developing countries, cervical cancer screening programs are very difficult to maintain. There is a complex infrastructure required. You need physicians and cytotechnologists to interpret the slides. You need specially trained individuals to collect the sample. You need transport media to store the particles. And then you need a call and recall system to contact women with abnormal results. And they can be quite expensive to run. And then once an abnormality is detected, it has to be treated. So for this reason, our part of the world hasn't been as successful in terms of cervical cancer screening programs as well-developed countries. And if a small portion of the country is screened, then we won't see an impact at all. And if screening goes up, as we discussed, the rates and the deaths would go down. And you need screening rates of upwards of 80% to make a meaningful impact. So in terms of screening guidelines, in terms of cervical cytology, there are several methods of screening. We can do testing with cervical cytology, which detects the abnormalities in the pap smear. We generally start at 21 and we do every 3 years. The recommendation used to be every year, but it's now known that in a well-screened population, that we do not need the screening more often, would not lead to decreased rates, because even if a precancerous lesion developed in the screening interval, the time that it takes to develop cervical cancer is so long that we can safely detect the precancerous lesion and the women will not be at risk. Then for women who are immunosuppressed, we still recommend yearly screening, or if you had a prior abnormal high-grade lesion or cancer, we recommend that you would continue to have your annual screening. And if you're older, some guidelines say 65 and older, and you've had several negative pap smears in the prior 10 years, or you've had a hysterectomy for benign causes such as fibroids or something that's non-cancer, abnormal bleeding, then the chance of you developing cervical cancer is low. And even if you get the vaccine, because it's not 100% against all strains, is essentially 99% against the strains that it protect for, then the chance of cervical cancer still exists even if you get the vaccine. So they still recommend screening, even though the risk is low. We still recommend that you get the vaccine. And other forms of screening would involve, we can always do tests for the HPV virus itself. We can test for the high-risk types. So there are several models. You could do a blended approach where you do a pap smear and HPV tests at the age of 30, and the data suggests that if both are negative, then you can go 5 years without screening. So this does not negate the need for the annual examination, because the gynecologists still screen for other women's health issues such as ovarian cancer. And of course, we need to evaluate our patients for these things. So this chart basically showed that there are various types of abnormalities that would be reported, but if there is an abnormality, then we need to go on to do a definitive test. So the pap smear is not a diagnostic tool is a screening test. So it tells you that something is wrong and you need to do another test to figure out exactly what is wrong before treatment. And this particular modality where we evaluate abnormal cytology or abnormal results is called colposcopy. Okay, so colposcopy is essentially reviewing or looking at the genitalia under magnification. Okay, and with respect to the cervix, we'll have to see the transformation zone and the lower areas. We can also look at the vagina and the vulva as well, because as the data show, it's possible to get vulva and vaginal cancer related to HPV, even though the incidence is far less than with cervical cancer. So we tend to look at the cervix under magnification. We apply special stains. One is acetic acid and the other one is Luger's iodine, if the patient is not allergic to that. Any abnormality detected, we would do a biopsy and send that for further analysis. And once we get those results, we'll determine what treatment needs to be done. Okay, so one of the things we tend to look for does it stain white or turn transparent? Is it elevated? Do have new vessel growth and that sort of thing? And we can use various risk assessment measures to determine the grade of the cancer. Before we go on to the various types of cancers we might detect, we highlighted that we can screen with a pap smear, we can screen with a HPV test with a pap smear, we can screen with the HPV test only. And in some countries that cannot afford either a HPV test every 5 years from the age of 30, those countries do what we call visual inspection of the cervix. So they either use Luger's iodine or acetic acid. They would bring all the women in a remote area. They would have specially trained community individuals. They would apply the dyes and visualize the cervix with low powered magnification. And when an abnormality is detected, it's treated on the spot with either an excisional procedure or cryotherapy. And this is also an effective method of reducing cervix cancer. So in some parts of Jamaica, they have implemented this because it takes about 6 months to get back a pap result in some countries, even though at one point, but it is much better now. And in Guyana, their national program for pap smear include visual inspection with acetic acid because they simply cannot afford the infrastructure for pap smears, and pap smears are mainly done in the private sector. So sometimes we may see a mass, or the biopsy result may come back as cancer, and there are different kinds. So there may be squamous cells, which account for the majority. Squamous cells are the type of cells we find on the skin. There may be glandular cells because the cervix produce mucus and the discharge and all of that during sexual excitation. So you may have cancer coming from those glands, and so those are adenocarcinomas, or they may be mixed. And we could have a myriad of symptoms associated with cervix cancer. So the question is, does flank pain, edema, or blood in the urine, or blood in the rectum, or strain or pain on passing stool, or massive bleeding? And of course, the response is all of the above, because depending on the stage, the symptoms may range from asymptomatic or abnormal biopsy result. As the disease progresses, you might get a malodorous discharge or bleeding after sex. There may be blood in the urine or pain on urination. If it begins to infiltrate the surrounding structures, such as the muscle, it may cause pain. And if it blocks the lymph glands, it causes swelling of the lower legs. It may invade into the bladder, so you get an abnormal development of a fistula, so blood and urine comes to the vagina. And if it invades the rectum posteriorly, stool comes to the vagina. So that's not a good way to go from a preventable disease. And then if we have lung mets and bone mets and upper abdominal disease, then you may get swelling, shortness of breath, and the associated symptoms with that. And of course, the physical exam, of course, may be normal in early cases and maybe only be able to detect at colposcopy, or you may see a gross erosion in the vagina and similarly in the rectum. So, so the symptoms really depend, the symptoms and the signs really depends on the stage and of the disease, okay? So we investigate by doing blood tests to check for anemia. The recommendation is that we need to examine the patient, do a biopsy, look in the bladder, look in the rectum, or image them in some manner. Check for obstruction of the kidneys, check for involvement of the lung. We can do CT scans if it's available. All these things, and blood tests to check for kidney function, as well as anemia and other metabolic disturbances. All that's part of the workup. And we can see that this images show a mass on the cervix. Okay. So otherwise this is the outline of the uterus, and we have an abnormal mass on the cervix, rectum, posterior, bladder, anteriorly. So that's a MRI image showing the cervix. So that's important because it helps us determine the spread of disease and help to choose the most appropriate form of management, because one size doesn't fit all. A PET scan, fortunately, we have PET scans now available in Nassau. And so we can detect very early spread by doing a PET scan, and the abnormal areas would light up if they're involved. So, and they have special machines to measure the intensity. So even though it light up, it has to be light, also intense to show the abnormality. And if the disease is confined to the cervix, we consider it stage 1. For lesions more than 4 centimeters, that's important, because if it's a bulky tumor, surgery becomes risky and the chance of cure is decreased the larger the lesion. And as such, we'll treat with other modalities such as chemoradiation. So if stage 2 would be disease involving the vagina and the tissue next to the vagina, stage 3 would involve the lower vagina, the pelvic side wall, and the lymph nodes, and stage 4 disease tumor would invade the surrounding organs or spread to distant organs, and the survival decreases rapidly with each stage. So it's almost 100% for early disease, stage 1, 80 to 100% depending on which particular stage, former stage 1, and it is 10% by the time you get to stage 4. And we already highlighted the treatment, so we said surgery. So if it's early, we could just excise that part of the cervix involved, or we could do a simple hysterectomy or a more extensive excision of the cervix with the tissue next to the cervix in women who would like to have children. We could do what we call a radical hysterectomy, which is a more extensive hysterectomy, which it would involve moving the lymph glands, dissecting the ureters from the tissue next to the uterus and resecting that bit of tissue, and we will remove the ovaries only if the patient is postmenopausal, and that can get a high rate of cure. But if there are risk factors to suggest that the cancer may come back, such as lymphovascular space invasion, large tumor volume, then we would need to recommend chemotherapy and radiation. So chemotherapy and radiation, stage for stage, would give a similar cure rate to surgery alone. So we basically do the modality that would suit the patient best. So because radiations is associated with vaginal stenosis and secondary cancers 10 years or more later, not in everybody, but in some persons, then we only do radiation in advanced cases, and then it also has a poorer sexual function outcome. So because radiation could be associated with vaginal stenosis. So in younger women, we prefer to do surgery, and in older women with medical problems or in patients whose disease is advanced, we would recommend radiotherapy. Now, it has been shown that not only do you need external radiation planned by sophisticated CT machines, but you also need internal radiation, what we call brachytherapy. So we'll put a special device in the vagina through the cervix and deliver the radiation close to the tissue next to the cervix and to the cervix itself to help sterilize the area and eradicate the cancer. So it's very important. And the data basically show that chemo and radiation works better together. Now, sometimes if the disease is far beyond the pelvis, then we may only give chemotherapy. That's because or we may give a small dose of radiation to stop the bleeding and give chemotherapy. And that's because the radiation may control the local disease, but you also need to give chemotherapy to control the systemic disease. The radiation is a beam that points to one spot in the pelvis, the affected areas in this particular tumor, because whole body radiation is toxic and we will not give the dose to high enough to achieve the cure for some without adversely affecting the organ. So we need to give systemic chemotherapy, and there are a number of drugs that are available. We tend to use the Taxol and carboplatin or platinum-based chemotherapy regimes, and then we would this would prolong the survival significantly. And there are newer drugs that have come on board. Now, sometimes the cancer may come back, and we need to evaluate if the patient had surgery only before, then they could get radiation to deal with the residual tumor or the recurrent tumor. But if they had chemotherapy and radiation up front, and there's a small area to be removed, then we could remove the uterus and the bladder and the bowel, and the rectum posteriorly, and we call it a complete pelvic exenteration, and the patient will end up with a permanent colostomy. So the stool would come out against the anterior abdominal wall, and the disease would also, we have to bring a bag for the urine as well. So this is a difficult way to go, and we see that is still a vexing and persistent problem in our country. So despite all the advances in screening, despite all the advances in treatment, cervical cancer still remains a vexing problem. So we have targeted therapies such as Avastin, which basically targets the growth of blood vessels. And we have a monoclonal antibody called Keytruda, that's the brand name, and basically is an immune checkpoint inhibitor. So it basically is another way of controlling the disease. So we get into the area of targeted therapy. And the survival is not, but of course, will depend on the stage. We follow up the patients for many years to ensure that the disease is quiet. And we do physical examination and imaging to ensure that the disease remains asleep. And if there is advanced disease, the survival is less than 5%. Okay, so we focus on keeping the the patient comfortable, because we don't want to be given drugs with high toxicities without any benefit. So this is a particular vaccine issue, that cervical cancer is still a major global problem. In our data in the Bahamas suggests that only 10% of the women that should be screened is screened. That's some work done by Dr. Riley Butler. He's the famous gynecologist in the Bahamas. He's been here for a long time and has been a mentor to me. And we still see roughly um, 10 to 20 cases of cervical cancer every year. So if we have 100,000 women to be screened, that's roughly 15 to 20 cases per 100,000, which is high considering in North America and Australia it's less than 7 per 100,000 women. And this is a significant cost to the government. Radiation is expensive. We have to pay $15,000 and upward for your radiation treatment. Your chemotherapy can run you up to $10,000, even though it's provided by the government. Somebody has to bear the cost. And then we have to consider the cost in terms of the loss of income, because the patients are going to work, they're not getting treatment. Then there is loss of manpower. And whenever you have to break news to relatively young women, we see the earliest age that I'm aware of, since I've been at PMH for the last 20 years, was a 23-year-old with cervical cancer. And we still see 25s and 24-year-olds and 29-year-olds with cervical cancer for something that is preventable, and for something that the vaccine is available for in the government clinics. And so this is quite concerning, and that we have a tool we have tools to prevent cancer in the Bahamas, but it's still a significant problem. And it still breaks my heart, because we have to see these patients who come very late. The majority of our patients come beyond the point where we could do surgery, and we have to do the best we can to keep them going. The survival is good for early stage disease. The HPV vaccine is effective. So the global trend by WHO and PAHO right now is on their program towards the elimination of cervical cancer, which they help to implement over the next decade, is that they want to have programs and to encourage us in the developing countries to have vaccination programs. There's some data to suggest that 2 vaccines are effective as 3. So that's good news, especially if you're a government and you have to run a vaccination program at 0 and 6 months. And they're essentially pushing HPV testing for screening, because we've been trying since the invention of the PrEP, or all those decades ago, to have a good screening program. And even when Bloomfield was intimately involved with Dr. Bloomfield involved with the Cancer Society, he the data that he collected, including the pap smears done by the Cancer Society, suggests that only 15,000 pap smears are done in the Bahamas yearly, for a population of eligible women of about 100,000. So we're not doing enough. I want to applaud the Cancer Society for the good work that they're doing in terms of housing these women who need treatment. The Cancer Society also makes a contribution towards the cost of radiation and other treatments. They're involved in some of the screening campaigns, and we do get abnormal results which we have to treat for those campaigns. So the Cancer Society must be commended, and they should be supported as much as possible. So in summary, that we need to do better. We need to encourage all women to get their screening and their vaccination, because it is painful to see death from something that is preventable. So thank you very much. Okay.
Well, thank you, Dr. Holliday. I have a question. If someone is diagnosed with endometriosis and they left it unattended, do that grows into cancer?
Okay, so that's a good question. So for everybody, so endometriosis is a condition that has several theories with respect to how it develops. Firstly, there's a theory of retrograde menstruation. So the period flows into the belly and into the muscle of the uterus and cause pain and scarring. All right. So women tend to have painful periods, painful intercourse that develop collection of blood pockets inside the belly called endometriomas. And they they the result is infertility, so they can't get pregnant. They have a lot of pain, and the other theory has to do with what we call immune maladaptation, meaning the body can't absorb it when it goes in those abnormal areas. So um, they because the body can't absorb it, it stays and cause those effects as we discussed. Now, there is an association with clear cell cancers, all right, when the um, of the peritoneal cavity and the ovaries in endometriosis, but that only occurs in 1% of the population. So we certainly would encourage you to be evaluated. Your physician or your gynecologist would individualize your treatment. If we see endometriosis getting worse in postmenopausal women, we worry because it is hormonally driven. So as long as you're seeing your period, it should be bad. But once you stop seeing your period, it should get better. So if it get worse during menopause, we know it could be associated with cancer and it should be managed. So, okay.
Thank you. Any more questions? Anyone have any concerns? Ask the doctor now.
Yes. May I ask a question? Good evening.
Good evening, go right ahead.
Hi, Dr. Halliday. Um, I have a two-part question. You mentioned that you've seen someone as young, 23-year-olds with cervical cancer. What is the screening age for cervical cancer? Or Pap smear, is that the screening for cervical cancer?
Yes, that's correct. So,
So what is the age in the Bahamas for
yeah,
those
so
screenings?
we tend to use the American College of Obstetrics and Gynecology guidelines, which suggests that if we screen at the age of 21, we will detect the majority of cancers. Now we have to remember that even if young women get the human papilloma virus, the immune response is so strong that the majority would clear the virus and even clear severe precancerous lesions. Okay. So that's why the age of screening is 21. It used to be 18 or 10 years after the onset of intercourse. But what they found that even if sexually involved young adults, they would be able to clear the virus. Now, so that's why we use 21. Now, the other thing is that there is a cost effectiveness ratio. So you may have one or two persons that have cervical cancer at an age close to 21, or in some countries even younger, but governments can only afford to do the best for the majority. So it has to do with the science of public health and how you cover the majority of the population, and to get to treat the majority of the people. So when we did the audit at Princess Margaret Hospital, one of our postgrad students, Dr. Ejoma, and one of our recent consultants. She did an audit which showed that we did not have anybody below the age of 23 in our cancer registry. So it means that if the persons in the Bahamas started to screen at age 21, we would detect precancerous lesions and treat them, or if they unfortunately have early cancer, we can detect it early enough to effectively treat it. So I don't know
Okay.
if that answers the question.
It does, but my next question would be, you made another statement that the HPV vaccine can help to prevent cervical cancer and that it's available at government clinics.
Yes, that's correct.
What is the criteria for having this vaccine?
Okay. So it's the government of the Bahamas has decided to vaccinate all school age girls going from junior high, going into junior high, from primary school, from grade 6 to grade 7, from junior school to middle school. So there are very models of vaccination, and there are various models of vaccination. These models allow for trying to vaccinate the whole population, or we would vaccinate the groups that are at risk. So we'd start vaccinating from a specific point in time, those patients who are about to become sexually active. So they try to do that for all 11 plus girls in the Bahamas. Now, it's certainly available through your private physicians, and for the vaccine is recommended up to the age of 26. So that's from 9 to 26. Older women, we know that there is some immune response to the vaccine, but the issue becomes whether or not that's the most effective way to cover the population. And in terms of the overall public health benefit, that's debatable. But we certainly, most GPs, and gynecologists would still give it up to 45, because the early data showed that there was some benefit. But that will have to be on an individual basis. But the government would be constrained by the guidelines. But the policy is to try and vaccinate girls going from grade 6 to grade 7.
I
Thank you.
have a question, Dr. Halliday. My question is, how effective is the vaccine for somebody over 45?
Right. So that's the question. So for women who are HPV naive, meaning they're not exposed to HPV, then the vaccine is 99% type specific effective. Okay. So in other words, the vaccine contains 7 high risk types and is 99% effective against those 7 high risk types. And the Gardasil 4, the older one, contains 2 high risk types that is 99% effective against those 2 high risk types in preventing cervical dysplasia in women who are at risk. And that's simply because that's how it works. So women who are exposed to the virus, now we have it is not as effective. The vaccine may be as low as 50% effective. So that's why we still give it. So it's more or less hit and miss, and it's not the exact science. And the reason why we give it is because there are several serotypes, and often in clinical practice we don't often test for the type specific. Well, there are 2 ways. You could do the type specific testing, which is newer, or you could do a panel testing, which is a pregnancy test, which say you're positive for high risk you're positive for a high risk type, but it doesn't tell you which particular type. So, but the bottom line is we vaccinate because there's some data regarding cross protection, and there is some data to show that 50% may benefit after exposure, but because because this does not negate the need for regular follow-up, such as doing your colposcopies, doing your follow-up pap smears, doing the cryotherapy, the excision procedures, and all that's necessary to treat the vaccine. Some countries take the stance, well, that's not cost effective because the cytology and colposcopy and intervention in and of themselves are effective methods, and they cannot afford in their population program to have a 50% effective drug. So that's basically hit and miss. So that's the rationale. Does that answer your question? Okay, I see another question from Ms. Cooper. You can unmute yourself.
Yes, good evening again, and thank you so much for such an informative presentation. I had a little bit of an internet issue, so I just needed to be sure what I heard you say in reference to the frequency of having a pap smear, because you were saying something and then I heard something about 5 years.
Okay.
So could you just repeat that part, please? Thank you.
All right. So there are different models of screening. So you could have what we call you could have pap smear screening or cervical cytology every year. All right, which is that's done not every year, every 3 years, sorry. So you do cervical cytology every 3 years. We can do a conventional pap, which is you place it on a slide and fix it with alcohol. Or we can put it in a liquid-based preservative medium, which is a bit more sensitive. All right, but whichever method you use, we do that every 3 years. Now, when it comes to co-testing, after the age of 30, we can either do co-testing, which is the HPV test with the cervical cytology, or HPV test alone, depending on your infrastructure. And because that's why I took the time to show that cervical cancer has a long preclinical stage. You could have a HPV infection, which can clear the majority of people, but those with persistent infection would go on to have cervical cancer. So or cervical dysplasia. So if you did a pap smear at, let's say, year 0, but you get HPV infection in year 3 and it persists, by the time we do the HPV test and the cytology at the 5th year, then we will still be able to help you without any harm coming to you. So it's a cost-saving method by the health authorities, because screening more often would lead to interventions which over time be harmful, because we have issues with cervical stenosis and other such issues for that sort of thing. So we need to be mindful of that. And so therefore the 2 models of testing are there for cervical cytology every 3 years for life, or cervical cytology, and when you get to 30, you can, or 25, depending on your country, you can do co-testing. All right. And so I hope that answers the question.
Good evening. I have a question. You started to say something that I didn't fully get. If you had a hysterectomy or your cervix removed because of fibroids, there's still chances that you would be able to get cancer? Something you were saying?
Okay, that's an excellent question. That's an excellent question. So the teaching is that if you never had an abnormal pap smear and we did a hysterectomy, then it means that the chances of you developing cancer of the vagina is very low because it's associated with HPV infection. And cancer of the vagina is the rarest of all gynecological cancers. Now, if you did have an abnormal pap smear and you have uh, um, HPV in the genital tract, then we would recommend that you go on to have your vaginal vault smears because you could have precancerous lesions in the vagina as well. So that's why that's that particular recommendation. It has to do with risk assessment. So if you were low risk before the hysterectomy, you'll continue to be low risk. And if you're high risk before the hysterectomy, you'll continue to be high risk. Okay.
Thank you.
Any other questions?
Good evening. I posted a question in the two questions actually in the chat. One of them was, are you aware of any other testing campaign?
I'm losing your sound.
That
So, okay, I'm not hearing the sound from Juanita.
She put it in the chat and it says, what other testing campaigns are available other than Cancer Society of the Bahamas on the islands?
Okay, so thank you for the question. So, the government clinics are always available to do your screening. With COVID is a little difficult, but with an appointment, I'm sure it can be done in all the family of islands. Apart from the Cancer Society, I do not know of any particular group. Certainly with the uptake of the national health insurance, a lot of the private family physicians are able to provide you with your pap smear free of cost, as well as your blood tests. Well, not free of cost, free to you, but the government pays, and I guess everybody pays indirectly with their taxes. But as no, so it's covered. That's the point, really. So it's important for those who don't have national health to sign up, so that if you're uncomfortable going to the clinic or you prefer not to go, there are other areas where you can go. Certainly, most islands have a trained midwife that in times past the midwives used to do the pap smear, and in many islands, gynecologists from Nassau visit on a periodic basis to extend service to the family island. Okay, so I hope that answers the question. I see one more question in the chat. How old you? So basically, when do you stop doing a pap smear? That's what I gather from the question. And so the guidelines suggest that if you do a pap smear every 3 years and you have 3 normal pap smears, and you're in the last 10 years and you're over 65, you can not do your cervical screening or screen for pap smears. Now, if you've had issues with abnormal pap smears in the past, you should check with your healthcare provider so they could come up with a plan for you. So women who have cervical dysplasia, women who are immunocompromised from HIV, and who take immunosuppressive therapy for organ transplant, ulcerative colitis, and all those SLE and all those other conditions, then they should continue to be screened annually because they would be at risk for developing cervical cancer. So it's individualized. So it's something you would need to discuss with your healthcare provider. But in general, those recommendations would apply. So are there any other questions?
No other questions? So Dr. Halliday, again, very good talk and very informative talk. And you can see by the questions that it sparked a lot of interest. I think cervical cancer always sparks this type of discussion when we have this meeting. And I think you did a very excellent job in describing the disease process and what we need to do. I think overall, though, I think the population really needs to be more informed about the disease itself. I think we as healthcare professions and Cancer Society needs to go out there a bit more. We probably have to change our modus operandi because of the COVID. But like you said earlier, cancer still is thriving, and we need to, still get our input in trying to control the cancer, the cervical cancer in our country. But if no one has any more other questions, I will call it an evening, and hope we see you guys next month for our next monthly meeting. We see tonight we had 60 participants, which is very good and excellent. These Zoom meetings really bring people out. It's good. We get the word out and people know more about diseases and how to care for them and prevent them. So if there are no other questions, we can call it the evening.
Okay, thank you for having us. Thank you.